Thank you very much for your kind introduction. So now it's time to talk about bacterial infection. So before I talk about fungal infection, now is the time of the bacterial. So, and I will focus the attention on ventilator-associated pneumonia. So these are my disclosures, but let's start with some epidemiological data. So how frequent are respiratory tract infections in the ICU, so particular in intensive care medicine? So this is again the study that I showed you before, is the Empirical study led by Jean-Louis Vincent, and you can see that overall respiratory tract infections represent the most frequent infections in ICU. So over 7,000 infections overall, more than 4,500 were represented by respiratory infections, means more than 50% of all the infections in the ICU are respiratory tract infections. Another important point is how many of the infections that arise in the hospital in general and how many of the pneumonia present the highest mortality. You can see very well here in this paper of several years ago by Marin Kollef, in which they analyzed the mortality for the different types of pneumonia: community-acquired pneumonia, healthcare-associated pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. You can see very well the difference in terms of mortality. So ventilator-associated pneumonia present the highest mortality, with more or less 1/3 of the patients that died for this kind of infections. What do we know about the bugs? So what are the typical bugs in hospital-acquired pneumonia and also in ventilator-associated pneumonia? So in general, when we have early infections, we have typical pathogens that come from the community: Streptococcus pneumoniae and H. flu. These are the typical pathogens in the first 3-5 days of hospitalization. Then we have the middle pathogen, and the middle pathogen are represented by Staphylococcus aureus, mainly MRSA, and by the gram-negatives. What gram-negative? In general, Klebsiella is actually one of the main pathogens with E. coli, but also don't forget the importance of Pseudomonas aeruginosa, that is very important between day 6 to day 20. And then, in general, little bit later, we have Acinetobacter baumannii, and very late, we have Stenotrophomonas maltophilia. So, but in general, the key pathogens that we have between day 5 to day 15 are Staph and Enterobacteriaceae plus Pseudomonas. So when we look at the top 3 most prevalent nosocomial pathogens in the European countries, you can see that all of these European countries report different pathogens, but you can see that overall we can have Staphylococcus aureus first, or Pseudomonas aeruginosa, or sometimes other Enterobacteriaceae. In general, you know, Staph aureus and then Pseudomonas aeruginosa. We can have first and second or the third. So these are the most prevalent drugs. So one important point that you have to consider in the selection of the antibiotics is the effect of some risk factors for the promotion of multi-resistant organisms. So this is a very old study published by Trouillet, in which they analyze 3 groups of patients. Patients without mechanical with a very low exposure to mechanical ventilation and no exposure to antibiotics. Group 2, patients with antibiotics and lower than 7 days of mechanical ventilation. Group 3, patients with more than 7 days of mechanical ventilation. And the group 4, patient with a long mechanical ventilation and exposure to antimicrobials. You know where the resistant strains were in this group, group 4. The group 4 was the typical group for multi-resistant organisms: Pseudomonas, Acinetobacter, and MRSA. So you have to be careful, particularly in patients that present longer hospitalization with longer mechanical ventilation and exposure to antibiotics. So these are typically the patients that present higher risk to develop resistant strains. So in this second very nice paper published by Ignacio Martin-Loches in Intensive Care Medicine, they divide patients into groups. Group 1, where they have early ventilator-associated pneumonia and no risk factors for MDR. And Group 2, early VAP with risk factors for MDR and late VAP. You can see, look, MDR infections were equally present in the two populations. So what is the message from this study? It's not only important to consider the days of the mechanical ventilation, so early or late, but to consider risk factors for MDR. And logistic regression analysis identified that the presence of severe sepsis and septic shock and pneumonia developed in centers with greater than 25% prevalence of resistant strains independently associated with MDR. So, if you are in Russia, if you are in Moscow, that we know that is a city with a very high incidence of MDR, this is probably more important than the days on mechanical ventilation. Being in an ICU with a very high prevalence of MDR is probably more important than the days of hospitalization. This means that in Russia, if you have a patient with a ventilator-associated pneumonia, probably is important to suspect the resistant strains, even if the pneumonia happened very early, like in the first days of ventilation. So, in general, what do we know about the bad bugs in pneumonia, and particularly in ventilator-associated pneumonia? So we have these 4 bad bugs in pneumonia. We have Staphylococcus aureus methicillin resistance. We have Klebsiella pneumonia, KPC, and OXA, particularly in the area of Russia, you know, CRE. We have Acinetobacter, MDR, multi-drug resistant. We have Pseudomonas aeruginosa, MDR, and we have Enterobacteriaceae, ESBL. So this is the mix of the bugs that you can find in ventilator-associated pneumonia. So this is more or less what you have. So what is the prevalence of the carbapenem resistant in healthcare-associated infections in Europe? These are data from some years ago, but you can see very well that Acinetobacter represents the most problematic organism for the resistant to carbapenems, followed by Pseudomonas aeruginosa. 30% of the Pseudomonas aeruginosa strains are actually carbapenem resistant, and then we have more than 20% of the Klebsiella that are resistant to carbapenems. So these 3 bugs are the 3 most problematic for resistant to carbapenems. So in this context, how can we initiate an antibacterial therapy for ventilator-associated pneumonia? So what we know? We know that there are 2 very important points. The first one for ventilator-associated pneumonia is the time. Every minute time. This is the time from hypotension to the initiation of the treatment, and this is the time from the hypotension to the risk of death. So every hour's delay until appropriate therapy results in a 12% increase in mortality. Time, and second point, appropriate. We know that appropriate initial therapy decrease dramatically the mortality. These are all studies run in patients with ventilator-associated pneumonia. So there are 2 important points to be considered: the time and the appropriateness of the treatment. So these are the 2 key points to be considered when we choose antimicrobials for patients with ventilator-associated pneumonia. And in general, and this is my personal receipt, there are 7 main concepts that need to be considered in critically ill patients for choosing antimicrobials for ventilator-associated pneumonia. The first one is impact on bacterial resistance. Why I am considering this point? Because carbapenems, for instance, that are widely prescribed for critically ill patients for ventilator-associated pneumonia are very good drugs. However, they present an important impact on bacterial resistance. You know very well how the impact is important here in Russia. You are full of carbapenem-resistant strains. Then the second point, risk stratification. We cannot give to our patients in the ICU, for all the patients in the ICU, exactly the same antibiotic. We have to differentiate. Patient at risk for Pseudomonas, Patients at risk for Acinetobacter, patients at risk for ESBL, patients at risk for MRSA. And depend on the risk stratification, you have to give different antimicrobials. Then we have to improve diagnosis and diagnostics. We have to work on this point, specifically for ventilator-associated pneumonia. And then, when do we have to use combination therapy? When do we have to combine two active agents for gram-negative? And then, how to optimize the drug? Drug optimization means optimization of the dose. And then, de-escalation. When do we have to go for de-escalation? From 2 drugs to 1. And then, duration. This is probably one of the most important points. Duration of the treatment. We have to be shorter. Every time we can, short is better than long, even for ventilator-associated pneumonia. So this is more or less a scheme of antimicrobial stewardship that you can use in your ICU for patients with ventilator-associated pneumonia. This has been published by myself and Marin Köllev last year in intensive care medicine. So, if you suspect a ventilator-associated pneumonia in your patient, first of all, you have to obtain the following: microbiological samples, so for culture and special strains. Then, before starting an antibiotic, biomarkers, procalcitonin, in order to have the time 0 level of procalcitonin. Then, identify risk factors for infection with resistant strains. And then, if you have, use the rapid microbiological test. Then, you can prescribe an empiric antibiotic regimen employing a combination of agents targeting likely MDR based on your local epidemiology and based on patient risk factors. Then you have to monitor the clinical response. Start whatever you want, but then please monitor the response, temperature, white blood cell, hemodynamic parameters, organ function, and biomarkers level, PCT. Then, microbiological identification of pathogen. You have the bug isolate. Yes, you can. You have a significant improvement after 48, 96 hours of treatment. Yes, you can de-escalate based on the microbiological result and discontinue antibiotic after 7 to 10 days based on the site of infection and the pathogen. If you don't have a significant improvement after 3 days, probably it's good to review the dose to optimize in drug level, reculture for possible superinfection, or also consider non-infection cause of fever inflammation, or examine for abscess formation. If you don't have microbiological identification on day 3 or 4, but you have a significant improvement, you can consider discontinuation of antibiotics and limit the course to 7 to 10 days. This is, a very easy example of the pathway for the treatment of bacterial infections in the ICU. So, the point that I discussed before, for ventilator-associated pneumonia, do we need combination or do we need the monotherapy? So, based on this experience, that was quite old but one of the best in my opinion, they analyzed the mortality and different other outcome for combination or for monotherapy. And you can see that for the majority of the outcome, there were no difference in using combination or monotherapy. Look, duration of mechanical ventilation, duration of ICU stay, mortality, ICU mortality. But look, when they analyze the adequacy of the empiric therapy, patients treated with combination present more appropriateness. So don't forget that one of the main points that we have to address for patients with ventilator-associated pneumonia is try to give them an adequate treatment. And combination means more adequacy. And for this reason, my personal opinion is that for patients with ventilator-associated pneumonia, or in general hospital-acquired pneumonia, it's good to go for the combination therapy, at least in the initial choice. Then, the antimicrobial regimen should be promptly narrowed or discontinued based on culture and susceptibility profile results and on clinical stability. This is my message. And this is exactly what we have from the American guidelines. So these are the guidelines published by Khalil for ventilator-associated pneumonia, and you can see that if you have risk factors for MDR, like the ventilation support for pneumonia or septic shock, patient with bronchiectasis or cystic fibrosis, or IC units with more than 10 to 20 of MRSA, you have to have double coverage for gram-negative, means 2 active agents, like piperacillin, tazobacter, or meropenem, plus a second agent like amikacin or colistin, plus vancomycin or linezolid. Probably linezolid is better. And you know, for ventilator-associated pneumonia, these are typically the risk factors for MDR. Prior IV antibiotic use, septic shock, RADS with VAP, more than 5 days of hospitalization, or acute renal replacement. So these are the risk factors for that. And this is more or less what I personally suggest. And this was a review that we published with my group in 2012. You can see the backbone. So the backbone depends where you are. In which unit are you working? The backbone is actually represented by meropenem, imipenem, or dolipenem, or piptazo, plus a second agent based on your local epidemiology, plus linezolid. This was the scheme of 2012, when carbapenemases were not so important. And now, probably, this is an old scheme that doesn't work anymore, specifically for Russia. So, why I am telling you that? Because we have to move, probably, for carbapenem for all, carbapenem, to a carbapenem-sparing options. Are there any carbapenem-sparing options for our patients? Based on ESBL, for instance, if you have an ESBL infection, or if you suspect an ESBL infection, there are probably some possibilities. There are actually 2 very good possibilities for ESBL. One is ceftolozane and tazobactam that is not available in Russia, and the second is ceftazine avibactam. So, more or less, talking about the new options, the new antibiotics, how these new antibiotics will fit in our armamentarium and in our possible choices. Here you have the 4 bed bugs that we can find in ventilator-associated pneumonia: ESBL, carbapenem-resistant Enterobacteriaceae, MDR pseudomonas, and MDR Acinetobacter. And here you have the list of the new antibiotics. Discussing about the new ones that are available in Russia, talking about ceftazine avibactam. How ceftazine avibactam fit in your epidemiological situation? So ceftazine avibactam is active against ESBL, active against KPC and OXA48, not active against the metallo, but in Russia, here in Moscow, you are full of OXA48, active against MDR pseudomonas, not active against Acinetobacter. So, in some manner, for ventilator-associated pneumonia, represent an advantage comparing to the old options. So, in general, this is the ceftazine avibactam, and you can see very well regarding the activity against the different enzymes produced by Enterobacteriaceae and pseudomonas. You can see that ceftazine is active against ESBL, AMP-C, KPC, OXA is not active against a metallo. Don't forget this point, because if you suspect a metallo-beta-lactamase, you have to use other option or combine ceftazine avibactam with an option active against the metallo. So what do we know about ceftazine avibactam? So the drug has been approved for complicated intra-abdominal infections, complicated urinary, hospital-acquired pneumonia, including ventilator-associated pneumonia, and there is also the 4th indication, very important, when indicate for the treatment of infections due to aerobic gram-negative organisms in adult patients with limited treatment options. This is very important because allow the possibility to use this drug everywhere. Every time you suspect a resistant bug, you can use ceftazine avibactam. So, cover very well ESBL, but also pseudomonas. The gaps. The drug doesn't cover ESBL Acinetobacter, Burkholderia, Stenotrophomonas, NDM, Pseudomonas with ceftazine efflux pump, anaerobes, and also MRSA. So these are some gaps that is important to know. What we know about the plasma and ELF concentration, these are very important. You are critical care doctors, and you know how important is the concentration of the drug in epithelial lining fluid, especially for ventilator-associated pneumonia. And you can see very well, look, plasma and ELF. The ratio of the two drugs in the ELF is equal. So this means that we have adequate level in the plasma and in the epithelial lining fluid. Very good, specifically for ventilator-associated pneumonia. So the drug has been studied very well in many studies. I like to talk with you about the REPROVE trial, because the REPROVE trial is the one that demonstrated that ceftazine avibactam was not inferior to meropenem in ventilator-associated pneumonia. This is called REPROVE and has been published by Tony Torres this year in Lancet Infectious Disease. And you can see ceftazine avibactam 2.5 grams a day in 2-hour infusion compared to meropenem 1 gram Q8. And there was a non-inferiority trial with 12.5% of the margin of non-inferiority. So these are the characteristics of the patients enrolled. You can see very well a lot of patients with ceftazine avibactam. Many of them present ventilator-associated pneumonia, 33 and 35, many ventilated. And you can see also the Apache 2 score was 10 to 19 in 87%, and some of them present also Apache 2 score between 20 to 30, so very sick patients. The data show a non-inferiority of ceftazine avibactam with meropenem. So ceftazine avibactam demonstrates to be non-inferior to a carbapenem. But what is important, and I like to show you, is the sub-analysis of patients with ceftazine non-susceptible strains, like Pseudomonas or Enterobacteriaceae. And you can see very well that in all the analysis, the drug performed very well without any statistically significant difference, but every time superior to meropenem. Look, 58, 62, and 70, while meropenem was in the line of 50 to 60. So when there was a strain resistant to ceftazine, resistant to the backbone, ceftazine avibactam performed better than meropenem. What we know about ceftazine avibactam, not in the field of pneumonia, but in the field of carbapenem-resistant Enterobacteriaceae. So this is the compassionate use, European compassionate use, and you can see that they treat 36 patients with carbapenem-resistant Enterobacteriaceae and 2 with Pseudomonas. 60% of the infection were life-threatening. The median duration was 16 days. The majority of the use were in combination with the second agent, and they experienced quite good clinical and microbiological cure, 73%. And ceftazine avibactam shows promising clinical results for infection for which treatment options are limited. This was from Europe, but now I like to show you the data from United States. So they have a good experience because the drug has been launched more than 3 years ago, and this is the first experience by Shields. And the first experience by Shields show us some light and some shadows from the drug. The lights were, the drug worked very well with a 30-day survival of 76 days. However, from the other part, there were 27% of patients that experienced microbiological failure. And some ceftazine avibactam resistance was detected in 30% of the patients. And you know why? Probably for 2 reasons. PK/PD optimization. Probably many of them are critically ill patients, need probably longer infusion of the drug. And the second point, combo. In carbapenem-resistant Enterobacteriaceae, probably is better to use ceftazine avibactam in combination than in monotherapy, especially in critically ill patients. This is the first study, and then this is the second one that is much better than the previous one. Again, Shields, published last year in Antimicrobial Agent Chemotherapy. Patients with carbapenem-resistant Klebsiella pneumonia bacteremia, and he analyzed the efficacy of ceftazine avibactam with the one of carbapenem with aminoglycoside, carbapenem colistin odor, and you can see very well, very big difference between ceftazine avibactam and the other options, so 85%. And when they did the multivariate analysis, they demonstrate that the treatment with ceftazine avibactam was protective for mortality. So using ceftazine avibactam alone or in combination at the end demonstrate to be superior compared to all the other options for the treatment of Klebsiella pneumoniae bacteremia. So this is a very good message. And then the third message that has been cited this morning by another colleague was the one against colistin. We know that colistin actually represents the backbone for the treatment of carbapenem-resistant Enterobacteriaceae. In this experience, published last year in Clinical Infectious Disease, they analyzed the all-cause mortality at 30 days for patients treated with ceftazine avibactam and for whom treated with colistin, and you can see very well big difference in terms of mortality. So using ceftazine avibactam, there was an advantage even in terms of mortality. So for this reason, and I show you the actual guidelines for the treatment of KPC that I published with the Greeks and under the auspices of the European Society of Infectious Disease, mainly KPC, not OXA, but KPC and OXA are very similar in terms of susceptibility to the antimicrobials. And the first message is, if you have a KPC, but I would say if you have an OXA, in a sick patient in the ICU, please go for the combination. Whenever is the combination, it's better to combine two active drugs. And particularly, if you decide to use ceftazine avibactam, that is actually one of the drugs recommended, please, in severe patients, use the combination. Ceftazine avibactam plus a second agent. And what is the best second agent? I don't know in your setting, but you can see based on different MIC, and this is another recommendation, ceftazine avibactam plus genta or fosfomycin or tigacycline. So depend in which setting you are, but in general, if you have a sick patient, my suggestion, specifically if you have a pneumonia, is better if you use in combination with a second agent. So ceftazine avibactam is a nice drug, but has obviously some pros and some limitations. Which are the pros? The pros is pharmacokinetic characteristics, predictable pharmacokinetic, rapid tissue distribution, especially in the lung, renal excretion, very good safety profile. This is a beta-lactam. Inhibit ESBL, AMP-C, KPC, and OXA48. This means that it's very broad. Pseudomonas aeruginosa and Enterobacteriaceae enhanced activity, approved for empiric and target therapy, and this is an option to spur the carbapenems. Limitations: does not inhibit class B enzyme and many of the other class D. Not susceptible Acinetobacter and the anaerobes, avoid if beta-lactam allergy. And then there is the point, salvage versus empiric. When do we have to use the drug empirically? And do we have to use in the salvage therapy? In my opinion, in any case, if you target CRE, it's probably better to use the drug in combination if you target the CRE. So, this is my idea about how to use ceftazine avibactam empirically. So, these are the clinical entities. The clinical entities are severe sepsis related to nosocomial pneumonia, complicated urinary tract infections, complicated abdominal or suspect bacteremia, with risk factors for CRE and ESBL and Pseudomonas also. Typically, colonization, receipt of broad-spectrum antimicrobial, history of long hospitalization, invasive devices, immunosuppression, ICU admission. Critically ill patients, but is not enough. The most important consideration is the consideration of your local epidemiology. If you in your ICU unit, you have more than 20% of KPC or OXA, if you have more than 20% of ESBL, you are probably authorized to use this drug empirically in critically ill patients. So the last point I'd like to discuss with you is the one regarding Pseudomonas. Is ceftazine-avibactam a good drug for Pseudomonas aeruginosa infections? Because we know that in pneumonia we have Enterobacteriaceae, Klebsiella, E. coli, but we have also Pseudomonas. Do ceftazine-avibactam give an advantage in terms of activity for Pseudomonas? So this is an experience from recently published, and they show that 92% of the strain of Pseudomonas circulating still susceptible to ceftazine-avibactam. And you can see very well, different studies run in different parts of the world. Look, susceptibility is quite good for ceftazine-avibactam in Pseudomonas aeruginosa. So, if you have to target Pseudomonas in country with high MDR rate, like in Russia, what can we combine? You remember the slide that I showed you before? The one where we have meropenem, piptezo, doripenem, and meropenem. Now is more or less the same. In order to prescribe an empiric drug targeting Pseudomonas, you can have piptezo, meropenem, imipenem, but now we have also ceftazine-avibactam that need to be combined with a second agent based on your local epidemiology. Cipro, Levo, Genta, Amica, colistin, fosfomycin depend on the resistance rate to these two drugs. So in conclusion, what do we know actually about empiric treatment of gram-negative infections? You can see very well that we have new options. For ESBL, ceftazine-avibactam and ceftolozane-tazobactam. For CRE, KPC, and OXA, ceftazine-avibactam in combination with a second agent. For MDR-Acinetobacter, we don't have many alternatives to colistin rifampin or tigacycline rifampin or tigacycline colistin. And for Pseudomonas MDR, we have, obviously, we will have ceftolozane-tazobactam, but also ceftazine-avibactam as a backbone. So you can see that this drug fit in the armamentarium at least in three different situations: ESBL, CRE, and Pseudomonas aeruginosa. So my last recommendation is regarding the key rules for the management of ventilator-associated pneumonia. So first of all, in my opinion, avoid starting antimicrobials if useless. If you don't have infection, just colonization, please avoid to use antimicrobials. Then use high dose. Whenever you decide to use high dose for the initial treatment, if antimicrobial are started. Then stop early preemptive treatment. Maximal effort for diagnosis infection before treatment. So try to send sample to the lab in order to have more data. De-escalate as often as possible, respecting PD rules. Duration of treatment should be shorter than originally stated, and PCT or ID-driven approach both are good. The PCT, procalcitonin in order to de-escalate. Cautiously, inadequate initial treatment, immunocompromised patients, devices and foreign material, and be careful when you have MDR, XCR organisms, particularly CRE and Pseudomonas, they need to have probably a different approach. Again, if you didn't register before, please register now to website in order to obtain a presentation, and in order, if you want, to come to Venezia at the end of the year, 25th and 26th of October, to the HTAT conference that I organized there to discuss many of the points discussed today. Thank you very much for your attention.